and thanks for participation for this meeting, and especially to our foreign guests for their collaboration and cooperation. Today, we will talk in this session about high-risk subjects. I will define you who are those at high risk for breast cancer. As you know, in last 2 decades, breast cancer incidence rates and mortality is changed due to use of mammogram as a screening modality and reduction of use of hormone replacement therapy. But still, 1 of 8 women have breast cancer, a lifetime breast cancer risk. So discussion with the patient is not easy, telling the patient that she has 1 in 8 risk over her lifetime. So it is important not to overly frighten the patients. As you know, breast cancer is multifactorial disease, and breast cancer, these multifactorial factors can be divided in 2 categories. The epidemiological studies identified various characteristics that are associated with breast cancer. These risk factors is intrinsic or extrinsic risk factors. Intrinsic risk factors are endogenous hormonal factors, familial or genetic predispositions, and the benign breast lesions confirmed pathologically. Extrinsic risk factors are exogenous hormonal factors, geographic locations, diet, and environmental exposure. This risk factor can be divided in 2 categories, changeable or unchangeable. We cannot change some of the risk factors, such as obesity, diet, that we can change this risk factor, obesity, or use of oral contraceptive, hormone replacement therapy, smoking or alcohol consumption. But we cannot change some of risk factors. These are important. Most important are being a woman and aging. But some risk factors cause the high risk, such as genetic predisposition, genetic mutations, family history of breast cancer, personal history of some hyperplastic breast disease, personal history of cancer for contralateral breast, race, previous exposure of ionizing radiation, and the menstrual history. You see the relative risk of these factors. Most importance of this risk factor is family history of breast cancer or genetic predisposition. And the second leading cause for risk is some benign or prevalent histological lesions, and the radiation exposure is in 3rd place. We divide the risk factors magnitude in 3 categories, less than 2 or more than 4 or between them. Aging is most important, and 2 first-degree relatives with breast cancer, genetic mutations, and personal history of pre-malign or malign disease of breast. How we define the breast high risk? We used 4 parameters for definition of high risk. In young women who are known the carriers of hereditary susceptibility mutations, or their close relatives has mutation carriers. Or a young woman who has a strong family history of breast cancer, or history of chest wall radiation, or any pathological indices of high risk. The first parameters, I told that the genetic mutations. Breast cancer are caused by abnormal genes. The breast cancer diagnosed at young age can be due to inherited genetic mutations. But normal genes can acquire mutations. That is approximately 90% of breast cancers, the cause. For example, for these BRCA1, BRCA2 genes. These genes, BRCA2-1, you know, located on the chromosome 17 and has almost 1,000 mutations related to breast cancer. BRCA2 is located on 13, chromosome 13 has almost 800 mutations related to breast cancer. 5 to 10% of breast cancer patients have a hereditary form disease. Lifetime breast cancer risk in this group is 36 to 85%. There are some other mutations and some syndromes, as you know, leukemia and Cowden syndrome, etc. If we look at these genes are tumor suppressor genes, and what is their function? Their function is to keep the cells from growing out of control and involving in DNA damage response pathways. So, if the mutation is gone, mutations are inherited in an autosomal dominant pattern. If a mutated copy of one of these genes is inherited, leads to higher risk of second copy becoming mutated, which could cause breast cancer. If one good copy is present, it will still be able to stop abnormal cell growth. And cancer develops when second copy is or becomes dysfunctional. In simple explanation, we inherit 2 copies of each our genes, one from father, one from mother. If one parent has a faulty BRCA1 or BRCA2 gene, this can pass down their children. But each child has 50% chance to inheriting the parents' faulty gene. Others, 50% does not. A woman who inherits the faulty BRCA1 or BRCA2 gene will not always get cancer, but her chance to develop breast cancer or ovarian cancer during her lifetime much higher than gender population. You see that this figure, there is increasing cumulative risk in this group by the age. This table also shows same results. Another parameter related to the high risk is a strong family history of breast cancer in young women, especially in young women. An important risk factor is familial history of breast cancer with a first-degree relative with early onset of breast cancer. About 10% of breast cancer is related to family history of genetic mutations, I told previously. Not all women with a relative who had a breast cancer are same increased risk. Risk increase with age, the age of the relative, the number of relatives with the breast cancer, and relation between the subjects. In a meta-analysis, using data of 150,000 patients, the risk of breast cancer in a woman 3 times if the relative has a breast cancer before age 30. If the relative has a breast cancer after age 60, it is 1.5 times. If the family, there is a one affected first-degree relative, the risk is 1.8 times high. But there are more or 2 or more affected first-degree relatives, it is almost 3 times increase. Another factor for high risk is previous history of chest valve radiation. We know about the role of radiation, early knowledge about the carcinogenic effect of radiation was derived from studies of atomic bomb survivors, as you know. But now, therapeutic exposure to monitor or treat the disease is most significant cause of radiation induced by carcinogenesis. For carcinogenesis, risk of breast cancer increased with the use of fluoroscopies in tuberculosis patient, radiation treatment to chest area for Hodgkin lymphoma at early age. The women are most vulnerable during prepubertal years, but even women in their 40s who are exposed to radiation have an increased risk. The breast is one of the most sensitive tissue to the carcinogenic effect of radiation. That fractionated exposures are similar to single exposures of the same total dose in their ability to induce breast cancer. That risk remains high for many years after exposure, and that young women are especially vulnerable to radiation injury. Another factors related to high risk, the pathological indices. As you know, the atypical hyperplasia, lobular carcinoma in situ, radial scars is especially interested with the high risk. High risk, you know, a proliferative breast lesion, and diagnosed histologically, less than 5% of breast biopsies constitute the atypical hyperplasia. There is no classic mammographical findings. Biopsies performed for calcification approximately 70% of time, as you know. You see this slide, that is two or threefold increase if the patient has an atypical hyperplasia compared to epithelial hyperplasia. In for natural history, Arnold Forster Institute of Pathology study on 82 patients, 10% developed invasive cancer at an average of 10 years after diagnosis of atypical hyperplasia. But if the family history is take the attention, breast cancer detection demonstration project demonstrated that the 22-fold increase in average, comparing the average woman. So atypical hyperplasia, marker of increased risk. This is demonstrated in North Health study in 1997. Lobular carcinoma in situ, as you know, non-invasive multicentric proliferative lesions in cells in the lobes of terminal ducts. Ductal occlusion, lobular enlargement are key features, found to 0.5 to 8% of breast biopsies. No clinical or mammographic findings. It is average age between the 44 to 49 and the more common in Caucasian women. It is also precursor of invasive disease. Cancer found in 13% of patients having mastectomy for LCIS. Documented to increase the risk of subsequent invasive malignancy. 30% of the women with LCIS will develop a malignancy in the future. This is the data. If the patient has lobular carcinoma in situ for ipsilateral breast, and if he has a breast cancer for contralateral breast, you can see the risk for these patients. Radial scar is another lesion, as you know. Anderson et al. Reported 32 patients with no development of malignancy, but in North Health study demonstrated increased risk of invasive malignancy by twofold. If it is associated with atypical hyperplasia, risk increased to sixfold. Most common associated malignancy is tubular carcinoma. Consequent risk is equal to in ipsilateral and contralateral breast. So, high-risk indices, high risk includes those young women who will be referred to genetic concealing, or will be referred to more intensive breast cancer or ovarian cancer screening, and will be eligible for chemoprevention and chemopreventional clinical trials. Young women at high risk of breast cancer include some populations, such as the woman, Ashkenazi and Jewish descent, African American women. These young women are at high risk than young women general population, but do not necessarily fall into category absolute high risk. You can find some more information from this website. As a summary, I would say that how we define the high risk with the young woman, known carriers of hereditary susceptibility to mutation or close relative of mutation carriers, or young woman with a strong family history of breast cancer and or ovarian cancer, and or young woman with a history of chest wall radiation, and the young woman with pathological indices of high risk, such as atypical hyperplasia, lobular carcinoma in situ. Thank you for your attention.